Pharmacologic therapy is a fundamental component of pain management, including the treatment of headache disorders. The approach to medication often depends on the type, severity, and chronic nature of the pain, as well as individual patient factors and coexisting conditions. The goal of treatment extends beyond simply reducing pain intensity to enhancing patient functionality and overall quality of life. In managing pain through pharmacologic means, it is important to adopt an individualized approach. This involves considering the specific needs, characteristics, preferences, comorbidities, current medications, and the potential for adverse effects and drug interactions unique to each patient. A multimodal strategy is often employed, which combines different pharmacologic agents or pairs medication with non-pharmacologic strategies. This approach aims to optimize pain relief by achieving additive therapeutic effects while potentially reducing adverse effects, such as the opioid-sparing effect. Medications should be initiated at the lowest effective dose and gradually increased until the desired response is achieved, the maximum dose is reached, or tolerability issues develop. For pain that occurs acutely, medications are often given around the clock initially and then transition to as-needed use as the pain improves. For chronic pain, long-term use of certain medications, such as nonsteroidal anti-inflammatory drugs, carries risks to cardiovascular health and the gastrointestinal tract, which can occur even within days or weeks of consistent use. Regular monitoring of treatment outcomes is essential. This includes evaluating pain relief, functionality, and quality of life, as well as monitoring for adverse effects like sedation or constipation. Assessments should be performed using validated tools, with the frequency of evaluation depending on factors such as the medication used, its route of administration, the duration of action, and other concurrent therapies. Genetic variations among patients can influence how medications are metabolized and tolerated. Clinical guidelines exist for certain medications, including some nonsteroidal anti-inflammatory drugs, opioids, and antidepressants. For instance, individuals with rapid or poor metabolizer status for the enzyme CYP2D6 should avoid medications like codeine and tramadol due to increased risks of toxicity or insufficient pain relief. In conclusion, pharmacologic treatment remains a cornerstone of pain management. When developing an effective therapeutic plan, healthcare providers must carefully evaluate the potential benefits against the risks of adverse effects for each medication, both at the outset and throughout the course of treatment. Within the broader context of pharmacological therapy, the World Health Organization recommends a three-step ladder approach for managing acute and cancer pain. This approach begins with the use of non-opioid analgesics as the initial treatment, followed by escalation to weak or strong opioids depending on the patient's pain intensity, which can range from mild to severe. The first step involves non-opioid analgesics, which are often preferred as the primary therapy for mild to moderate pain. Acetaminophen, commonly known as Tylenol, is still considered a first-line treatment for some mild pain conditions. However, some guidelines have questioned its effectiveness for low back pain. Its exact mechanism is not completely understood, but is believed to involve modulation of prostaglandins in the central nervous system. Nonsteroidal anti-inflammatory drugs, which inhibit prostaglandin formation, are frequently recommended for conditions such as osteoarthritis, either in oral or topical form. These drugs are advised for use in cases of acute, subacute, and chronic low back pain after non-pharmacologic therapies have failed. Ketorolac, a particular nonsteroidal anti-inflammatory drug, is a suitable option in emergency settings because of its injectable formulation. It is administered at a dose of 60 mg via intramuscular injection or 30 mg intravenously every 6 hours, with a maximum daily dose of 120 mg. Studies have demonstrated that ketorolac significantly reduces pain scores in cases of acute migraine, leading to increased use in emergency departments for headache-related visits from 2007 to 2018. Contraindications for ketorolac include active peptic ulcer disease, renal insufficiency, severe asthma, and pregnancy during the third trimester. Naproxen is another nonsteroidal anti-inflammatory drug that has shown positive effects in placebo-controlled studies for headache relief. Moderate use of naproxen may also provide protection against the transformation of episodic migraine into chronic migraine. Other nonsteroidal anti-inflammatory drugs, such as diclofenac and ibuprofen, are also categorized as first-line treatments for mild to moderate migraine episodes. Topical analgesics provide the benefit of targeting local symptoms while minimizing systemic exposure and adverse effects. Examples include topical formulations of nonsteroidal anti-inflammatory drugs for conditions such as knee or hand osteoarthritis. Capsaicin, used for various peripheral neuropathic pain syndromes, requires repeated application over time to achieve desensitization and is not suitable for as-needed use. Lidocaine, another topical analgesic, is used for neuropathic pain, including postherpetic neuralgia. Coanalgesics, also known as adjuvants, are a diverse group of pharmacological agents that are not typically classified as primary pain relievers but are valuable in pain management due to their individual characteristics. They are particularly useful in managing chronic pain, especially when it has a neuropathic component. These agents are often incorporated into multimodal therapy to achieve additive therapeutic effects and potentially allow for lower doses of primary pain relievers, leading to a more favorable adverse effect profile. This approach combines medications from different classes of pain relievers to achieve superior pain relief. Among these, ergot alkaloids are a heterogeneous group of drugs derived from a fungus called Claviceps purpurea that grows on grains. Their pharmacological effects originate from their actions as partial agonists or antagonists at serotonergic, dopaminergic, and adrenergic receptors. Historically, drugs such as ergotamine and dihydroergotamine have been used as main treatments for acute migraine attacks. Their mechanism of action for acute migraine relief mainly involves effects on serotonin receptors, specifically the serotonin 1B and serotonin 1D receptors. Examples of these medications include ergotamine, which is often combined with caffeine in formulations like Cafragot, and dihydroergotamine, which can be administered via intranasal or intravenous routes. Ergotamine, on the other hand, is typically taken orally, usually with caffeine. In terms of efficacy, dihydroergotamine combined with an antiemetic such as metoclopramide has been shown to be effective in relieving migraines and preventing relapse. It may sometimes outperform other treatments like meperidine, valproate, and ketorolac. However, studies comparing dihydroergotamine alone to combination therapy with antiemetics are limited and tend to favor non-ergot therapies. Despite their benefits, ergot alkaloids are associated with a range of adverse effects, including pleuropulmonary and cardiac fibrosis, as well as valvular heart disease, especially due to their activity at serotonin receptors that can stimulate unwanted tissue growth. Because of these risks, these drugs are no longer frequently prescribed and have largely been replaced by triptan medications. They are contraindicated in individuals with cardiovascular disease, uncontrolled hypertension, and during pregnancy, as their vasoconstrictive properties can decrease uterine blood flow and potentially cause abortion. The European Medicines Agency has recommended discontinuing the use of ergot derivatives for the treatment of migraines. Triptans are indole derivatives that are widely recognized as the first-line therapy for moderate to severe acute migraine attacks, and they can also be used for mild to moderate attacks that respond poorly to nonspecific therapies. These medications function as selective agonists of the serotonin receptors known as 5-HT1B and 5-HT1D. These receptors are believed to be involved in providing immediate relief from migraine symptoms by stopping nerve signaling within the nociceptive pathways of the trigeminovascular system and by promoting constriction of cranial blood vessels. Examples of triptan medications include sumatriptan, which serves as the prototype, as well as almatriptan, elatriptan, frovatriptan, naratriptan, rizatriptan, and zolmitriptan, all of which are available for migraine treatment. Sumatriptan is also marketed in a fixed-dose combination with the nonsteroidal anti-inflammatory drug naproxen. These medications come in various formulations such as oral tablets, rapidly dissolving tablets, nasal sprays, and injections administered under the skin. The fastest and most effective delivery method is generally considered to be subcutaneous injection. In clinical use, triptans are effective for the acute treatment of migraine with or without aura, especially when taken as early as possible after the onset of symptoms. The efficacy of oral triptans decreases if taken more than 2 hours after symptoms begin, whereas the subcutaneous form of sumatriptan maintains its effectiveness over a longer period. There is no clear evidence indicating that one triptan is superior to others in overall effectiveness. However, rizatriptan and elatriptan are noted to have higher efficacy on a population basis. Frovatriptan and naratriptan tend to have a slower onset, but are generally well tolerated. If an initial triptan does not effectively relieve symptoms, switching to another medication within the same class or exploring different therapies, such as medications called gepants or dihydroergotamines, can be beneficial. Common side effects include reactions at the injection site when taking the subcutaneous form, as well as dizziness, abnormal sensations, weakness, fatigue, flushing, and feelings of pressure, tightness, or pain in the chest, neck, or jaw. Serious but rare cardiac events, such as spasms of the coronary arteries and irregular heart rhythms, have been associated with triptan use, primarily in patients with risk factors for heart disease. Consequently, triptans are contraindicated in individuals with a history of coronary artery disease, stroke, transient ischemic attack, cerebrovascular or peripheral vascular disease, certain types of migraine such as hemiplegic or basilar migraine, or uncontrolled high blood pressure. Although rare, serotonin syndrome, a severe condition resulting from excessive stimulation of serotonin receptors, can occur, especially when triptans are used together with antidepressants such as selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, or monoamine oxidase inhibitors. Gepants are a newer class of small molecule drugs that act as antagonists of the calcitonin gene-related peptide receptor. This peptide is a key neurotransmitter involved in the development of migraines. The mechanism of action of gepants involves blocking the receptor for calcitonin gene-related peptide, which in turn inhibits vasodilation and neurogenic inflammation, both of which are associated with migraine symptoms. Examples of gepants include abrogepant, rimegepant, adogepant, and zavegepant. Abrogepant and rimegepant are administered orally, whereas zavegepant is available as an intranasal spray. Rimegepant is approved for both acute and preventive treatment of migraines, while adogepant is designated for preventive use. In terms of efficacy, gepants are effective in the acute treatment of migraines. They have demonstrated superiority over placebo in achieving pain freedom and relief from most bothersome symptoms within 2 hours of administration. Regarding their safety profile, a significant advantage of gepants over triptans is that they do not cause vasoconstriction, making them a suitable option for patients who have cardiovascular or cerebrovascular risk factors where triptans are contraindicated. Generally, gepants are well tolerated and have a low incidence of adverse events compared to triptans. Preclinical data suggests that gepants are unlikely to be associated with medication overuse headache. However, they should be avoided in patients taking strong inhibitors of the enzyme cytochrome P453A4. Although they work by preventing vasodilation, caution is advised for patients at very high risk of stroke, because animal models indicate that their use may increase brain infarcts when administered in the context of experimentally occluded middle cerebral arteries. Ditans are a new class of drugs used for the rapid treatment of migraines. They are different from triptans and gepants. These drugs work by specifically activating the 5-HT1F receptor, which is found in both the central and peripheral nervous systems, but not in blood vessels. An example of a ditan is lasmiditan, which has been approved for use in treating acute migraine attacks. Its effectiveness has been demonstrated in clinical studies showing it is more effective than a placebo. Unlike triptans, lasmiditan targets neural pathways rather than blood vessels. One of the main advantages of ditans is that they do not have effects on blood vessels, which makes them a safer option for patients with cardiovascular or cerebrovascular diseases who cannot use triptans. The most common side effects of these drugs include dizziness, which occurs in about 15% of patients, and drowsiness, affecting around 6%. Patients are advised not to drive for 8 hours after taking the medication because of these sedative effects. Corticosteroids, such as dexamethasone and methylprednisolone, are sometimes used in emergency departments to prevent the recurrence of migraine headaches. Their usage has increased over time, rising from 2.7% of headache-related emergency visits between 2007 and 2010 to 6.2% during 2015 to 2018. In addition to corticosteroids, antiemetics and diphenhydramine are commonly administered in emergency settings. Dopamine receptor antagonists, including prochlorperazine and metoclopramide, as well as drugs that block serotonin receptors like ondansetron, are frequently used to treat nausea and vomiting associated with headaches. Studies have shown that these medications are effective in reducing pain and nausea during acute migraine attacks. Prochlorperazine and metoclopramide are specifically recommended by the American Headache Society for managing migraines in the emergency department. Diphenhydramine is often used alongside these antiemetics, especially to prevent or treat side effects such as movement disorders caused by dopamine receptor antagonists. The use of diphenhydramine in headache-related emergency visits has significantly increased, from 16.5% to 35.8% between 2007 and 2018. Furthermore, about 85.5% of diphenhydramine administration is combined with dopamine receptor antagonists. Midazolam, a sedative, and diphenhydramine have also been found to be effective in treating the movement disorders induced by metoclopramide. In the broader context of pharmacologic pain management, choanalgesics play a vital role as part of a comprehensive, multimodal approach. These medications aim to optimize pain relief, enhance patients' functionality and quality of life, and minimize adverse effects. This strategy often involves lower doses of primary analgesics and is especially important when a neuropathic component is involved. Clinicians should carefully evaluate the potential benefits and risks of adverse effects associated with each medication both at the start of therapy and during ongoing treatment to determine the most effective and safest therapeutic plan. Valproic acid plays a specific, though often adjunctive, role in the management of acute migraine attacks, particularly in emergency department settings. It is broadly recognized as an anti-seizure medication. Other medications in this category, such as carbamazepine and oxcarbazepine, work by blocking voltage-gated sodium channels and enhancing the effects of gamma-aminobutyric acid, or GABA. Some studies suggest that valproic acid can be effective in treating migraines. For example, one study found that 75% of patients experienced relief of symptoms within 50 minutes. Another study indicated that an intravenous dose of 800 milligrams provided pain relief within 1 hour and maintained pain freedom for 24 hours, with results comparable to a dose of 1 gram of acetylsalicylic acid. Importantly, no adverse events were reported in either study. However, evidence from meta-analyses indicates that valproic acid is not superior to other treatments commonly used for acute migraines, such as dopamine antagonists, nonsteroidal anti-inflammatory drugs, or triptans. A well-designed, highly reliable study demonstrated that ketorolac and metoclopramide were more effective than valproic acid for headache relief at 1 hour and continued relief at 48 hours. Additionally, another study showed that prochlorperazine led to a significantly greater reduction in pain intensity compared to valproic acid at 60 minutes. In clinical practice, valproic acid is generally considered a second-line treatment for acute migraine attacks in emergency settings. Its use is typically classified as a treatment option that may be offered, but with limited supporting evidence. The level of evidence for its effectiveness is regarded as weak, and it is generally recommended that it not replace treatments with higher levels of proven efficacy as a first-line option. A reasonable approach involves administering a loading dose of 800 to 1,000 milligrams intravenously. This can be considered as an adjunct therapy after other agents have failed, provided that pregnancy has been ruled out. Beyond its use in treating acute attacks, there is also evidence supporting the use of valproic acid for migraine prevention. Regarding safety and contraindications, key adverse effects include liver enzyme elevation, known as transaminitis, and cognitive side effects. Valproic acid is teratogenic, which means it can cause birth defects. As a result, it is contraindicated in pregnant women. Medical guidelines often recommend avoiding the use of related formulations, such as D-valproex, in women of childbearing age due to the risk of impaired cognitive development in children born to mothers who took these medications during pregnancy. Additional contraindications include liver disease and urea cycle disorders. In some studies examining treatments for migraines, the overall rate of adverse events associated with valproic acid was comparable to that of other medications used for similar purposes. Other pharmacologic and emerging therapies for headache disorders include several agents that are currently being studied or used with caution. Propofol is a rapid-acting intravenous anesthetic that has shown promise as a rescue therapy for acute and refractory migraines in some studies. It has been associated with improvements in pain and the resolution of symptoms such as sensitivity to light and sound. However, the evidence supporting its use is limited due to small sample sizes, varying doses, and suboptimal comparison groups. Additionally, its safety profile in emergency department settings requires further research. Ketamine, another intravenous agent, has been utilized for the subacute treatment of refractory chronic migraines, although more evidence is needed to establish its efficacy and safety for this purpose. Medical cannabis has been studied for neuropathic pain, but its role in treating chronic pain and migraine remains unclear. Questions regarding appropriate routes of administration, dosing, and monitoring continue to need clarification. Exploratory studies on psilocybin and lysergic acid diethylamide suggest potential benefits in migraine suppression and cluster headache relief, but these findings are preliminary. Overall, pharmacologic therapy for headache disorders is complex and evolving. The field is moving toward personalized, evidence-based approaches that combine various medication classes. These strategies often involve integrating pharmacologic treatments with non-pharmacologic methods. While traditional analgesics and medications specific to migraines continue to be central components of therapy, ongoing research and increased understanding of drug interactions and individual patient factors are progressively refining treatment guidelines. Preventive treatment aims to reduce how often, how severe, and how long migraine attacks last, as well as to improve the body's response to immediate or acute treatments. It is generally considered for patients who experience frequent migraines, such as those with 15 or more headache days per month, which is classified as chronic migraine, or for those whose migraines significantly affect their quality of life. Preventive medication is usually tried for a period of 2 to 3 months at an appropriate dose to assess effectiveness. The decision to escalate or modify preventive treatment involves a stepwise approach based on the number of drugs that have failed. Several classes of oral medications have been proven effective for preventing migraines. These include beta blockers, such as metoprolol, propranolol, timolol, atenolol, and nadolol. Antiepileptic medications like topiramate and D-valproate sodium, also known as valproate sodium, are commonly used. However, valproate should be avoided in women of childbearing potential who are not using proper birth control. Other medications include certain antidepressants, such as amitriptyline and nortriptyline, which are tricyclic antidepressants, as well as venlafaxine and duloxetine, which are serotonin norepinephrine reuptake inhibitors. Calcium channel blockers like flunarizine and medications that inhibit the renin-angiotensin system, including candesartan and lisinopril, are also utilized in preventing migraines. Onabotulinum toxin A is an effective preventive treatment for chronic migraine, which is characterized by 15 or more headache days per month. It is usually administered through injections approximately every 3 months. Newer preventive treatments target the calcitonin gene-related peptide or its receptor. These monoclonal antibodies have demonstrated both efficacy and safety for individuals suffering from episodic and chronic migraine. Examples include eptinezumab, which is given intravenously on a quarterly basis, erinyumab, administered subcutaneously once a month, fremanezumab, given either monthly or quarterly through subcutaneous injections, and galcanezumab, which is injected subcutaneously monthly after an initial loading dose. Typically, initiating treatment with these monoclonal antibodies requires a diagnosis of migraine and a history indicating inadequate response or tolerability issues with existing preventive medications. For cases of refractory migraine, a rational polypharmacy approach may be considered. This involves combining preventive drugs from different classes or pairing a calcitonin gene-related peptide monoclonal antibody with onabotulinum toxin A or a medication known as Agepant. Additionally, There is some evidence supporting the use of older medications such as topiramate and amitriptyline in combination to manage refractory cases. Medication overuse headache is a chronic condition that develops in patients who have a primary headache disorder and frequently use pain relief medications for at least 3 months. This condition can sometimes mimic other headache types, presenting as a chronic daily headache that does not respond to both acute and preventive migraine treatments. Because of this, it is important to consider medication overuse headache as a possible diagnosis when evaluating refractory migraines. The risk of developing medication overuse headache increases with the frequent use of simple analgesics such as acetaminophen and nonsteroidal anti-inflammatory drugs, especially if taken at least 15 days each month. The risk also rises with the use of certain other medications, including triptans, ergot alkaloids, and opioids, when used at least 10 days per month. Opioids and barbiturates are particularly associated with a higher risk of medication overuse headache. Confirmation of this condition requires withdrawal of the medications believed to be causing the headache. A significant improvement in headache after stopping these medications typically confirms the diagnosis. Refractory migraine is a condition where the migraine does not respond to typical treatments or cures. Its diagnosis, underlying mechanisms, and management strategies are complex and remain the subject of ongoing research. Currently, there is no universally accepted set of diagnostic criteria for refractory migraine, as various groups have proposed different guidelines. It is often viewed as a subtype of chronic migraine or as a progression from it. A significant challenge in diagnosis is distinguishing refractory migraine from medication overuse headache, a condition caused by excessive use of pain relief medications. Patients with refractory migraine frequently suffer from other pain-related conditions, which are especially common in chronic migraine. These may include non-pain conditions such as depression, anxiety, insomnia, postural orthostatic tachycardia syndrome, and hypermobility. These comorbidities can contribute to an increase in the frequency and severity of migraine attacks. A key factor involved in refractory migraine is central sensitization, a process where nociceptive pathways in the nervous system become hyperactive. This hyperactivation is associated with the development of chronic pain states, longer duration of illness, increased headache frequency, and poorer responses to treatment. It is hypothesized that central sensitization may serve as a predictive factor for refractory migraine, although further research is needed to confirm this link. Understanding these aspects is essential for accurate diagnosis and effective management of headache disorders, including refractory migraine. Understanding headache disorders, especially migraine, is essential in medical education due to their significant impact on patient disability and quality of life. This summary aims to explain key concepts related to the pathophysiology, diagnosis, and management of migraine. Headache is a broad term used to describe pain in the head or neck, whereas migraine is a specific type of primary headache disorder. Approximately 90% of people experience headache at some point in their lives. These headaches can either be primary, occurring without an underlying medical condition, or secondary, caused by another medical disorder. It is important to note that relief from headache through pain medications alone cannot distinguish between primary and secondary headache disorders. Migraine affects about 12% of the population and is considered the most disabling form of primary headache, characterized by distinctive features and a complex neurobiological basis. The current understanding of migraine as a disorder involves both neurovascular and sensory processing components. Contrary to the old belief that migraine is mainly a vascular disorder caused by blood vessel dilation, this theory has been largely dismissed. Key elements in migraine's pathophysiology include the trigeminovascular system, which plays a central role during the pain phase. This system involves peripheral nerve fibers from the trigeminal ganglion that innervate intracranial blood vessels and meninges, converging within a specific brainstem region. Activation of pathways in this system results in the release of neuropeptides such as calcitonin gene-related peptide and pituitary adenylate cyclase activating polypeptide. These substances have potent effects on blood vessel dilation and contribute to migraine susceptibility by sensitizing neural pathways. The peptide calcitonin gene-related peptide has become a primary target for newer migraine treatments. Another important mechanism is cortical spreading depression, which describes a wave of neuronal and glial depolarization in the cerebral cortex. This process underpins the neurological symptoms known as aura, which often precede or accompany the headache. Central sensitization, particularly within the nerve fibers in the lower part of the brainstem, plays a crucial role in the development of chronic migraine. It leads to increased sensitivity to stimuli and altered pain regulation. Various brain regions are involved in migraine. The hypothalamus is linked to premonitory symptoms such as mood changes and food cravings, as well as the initiation of migraine attacks. The thalamus is involved in sensory processing and central sensitization, while the brainstem and cortex exhibit functional changes throughout an attack. Additionally, migraine often runs in families due to genetic factors. Mutations affecting ion channels in nerve cell membranes can lead to altered nerve excitability, especially in cases with aura. The clinical presentation of migraine typically involves 4 overlapping phases: premonitory, aura, headache, and postdrome. The premonitory phase occurs hours to days before the headache and may include symptoms such as yawning, mood changes, neck pain, and food cravings, likely linked to hypothalamic activation. About 20 to 25% of patients experience aura, characterized by transient neurological symptoms, most often visual disturbances like shimmering lights or zigzag patterns that develop gradually. Recognizing aura helps differentiate migraine from other neurological conditions, such as stroke. The headache phase usually presents as a throbbing or pulsating pain, often on one side of the head, and can range from moderate to severe. Physical activity often worsens the pain, which is frequently accompanied by nausea, vomiting, sensitivity to light and sound, and skin sensations like pain from normally non-painful stimuli. These attacks typically last between 4 and 72 hours if untreated. After the headache subsides, some individuals experience postdrome symptoms such as fatigue and neck pain that can persist for several hours. Diagnosis relies mainly on clinical history and examination, with criteria established by the International Classification of Headache Disorders. It is crucial to exclude other serious conditions by checking for red flag symptoms, including sudden, severe headaches, new neurological deficits, new headaches in individuals over 50 years old, or changes in mental status. Neuroimaging techniques like computed tomography or magnetic resonance imaging are generally unnecessary if typical migraine features are present and no red flags are observed, although they are warranted in atypical or suspicious cases. Currently, there are no specific blood tests or biomarkers to confirm a migraine diagnosis. Chronic migraine is diagnosed when a person experiences headache on at least 15 days per month over 3 months, with at least 8 of those days meeting criteria for migraine. Additionally, medication overuse headache may occur when individuals frequently use pain medications for at least 3 months, which can mimic refractory migraine and should be carefully ruled out. Management of migraine primarily involves pharmacological therapy, which should be tailored individually and involve various strategies to optimize outcomes. For acute attacks, non-opioid pain relievers such as nonsteroidal anti-inflammatory drugs are usually the first choice for mild to moderate pain. For more severe attacks, medications that specifically target migraine pathways are employed. These include serotonin receptor agonists, which induce cranial blood vessel constriction and inhibit nerve signaling, though they are contraindicated in patients with cardiovascular or cerebrovascular disease due to their vasoconstrictive effects. Newer options like calcitonin gene-related peptide receptor antagonists are effective because they are not vasoconstrictive, making them suitable for patients with cardiovascular risk factors. Similarly, selective serotonin receptor agonists that do not affect blood vessels are available and are beneficial for patients unable to take other medications. Historically used ergot alkaloids are now less common due to their adverse effects and contraindications. In emergency settings, medications that block dopamine receptors are often used alongside antihistamines to reduce movement-related side effects. Corticosteroids may also be administered to reduce the likelihood of headache recurrence. Overall, treatment strategies should aim to reduce the frequency and severity of attacks while minimizing side effects, incorporating both medication and non-pharmacological approaches. Prevention of migraine attacks aims to reduce their frequency, severity, and duration, as well as to improve responsiveness to acute treatments. These preventive measures are considered particularly for individuals experiencing frequent migraines, such as those with 15 or more headache days per month, or for those whose migraines significantly impact their quality of life. Established oral medications include beta blockers like metoprolol, antiepileptic drugs such as topiramate and D-valproex, and antidepressants like amitriptyline and venlafaxine. For chronic migraine, onabotulinumtoxinA is an effective preventive treatment administered through injections approximately every 3 months. Newer treatment options involve monoclonal antibodies targeting the calcitonin gene-related peptide pathway, such as eptinezumab and erinyumab. These are administered via injection and are suitable for both episodic and chronic migraine. Coanalgesics, also known as adjuvants, form a diverse group of agents that include certain anti-seizure medications like gabapentinoids and carbamazepine, as well as antidepressants such as tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors. These agents are valuable in managing chronic pain, especially when there is a neuropathic component, and they support a multimodal approach to treatment. Using these medications can also help in lowering the doses of primary analgesics. Nutraceuticals and supplements such as magnesium citrate, coenzyme Q10, and riboflavin are also suggested for preventing migraines. In the context of treatment, refractory migraine refers to cases where migraines resist standard treatments or cures. This is a complex and actively researched area that must be differentiated from medication overuse headache. Understanding these various aspects of migraine, from its underlying neurobiology to its diverse manifestations and treatments, is essential for effective clinical practice.